I am
No way.
was.
Right. I was like, no way.
Okay, guys. I think we'll go ahead and get started. Just real quickly, guys, just for fun, raise your hand if you were here for the study club before COVID. And then if you weren't ever part of the study club before. I love that. We had, this is the 8th year of the study club. I think it's either the 7th or 8th year. And we've obviously been on a 4-year hiatus. The last meeting that we had was, I think it was in January or February of 2020. And so getting a chance to start it back up again has been something that's been on the to-do list. I owe a lot of debt of gratitude to Bobby Cohan and Rochelle Cohen at First Hill Study Club and West Seattle Study Club because they got there started, and I started to feel bad about not having restarted hours. So it's very gratifying to have so many of the offices that we work with represented here tonight. The first speaker that I knew I wanted to have was Dr. Michel Azer. Michel and I first met on an online forum called Grindr. No, sorry. No, we met on a Facebook group called RIPE, which stood for the
Restorative Implant Excellence.
Full protocol. Okay. And so Michel and I were both serial contributors to this now about 86,000 person Facebook group. And at the time, Michel was a resident at Boston University, and I was an established periodontist. And I was really interested by how much he knew, the cases that he would post as a resident, so much so that we really tried very hard to get Dr. Azer to come up and work with us in Seattle. But as it turned out, Dr. Azer and his wife Maha decided to set roots down in Houston, Texas. Claire and I have been blessed to be part of Michel's practice growth. He opened the Texas Dental Implant Center in 2021 and has grown into a sought-after full arch practice in the Texas area. Dr. Azer finished his Perio residency at Boston University. A warm round of applause for our first speaker back, Dr. Michel.
It always amazes me when Tom speaks. I feel like my words are not coming out. He's just too good when he speaks. So I knew Tom through RIPE, and I knew also how good he is as a clinician, as a practice owner. So Tom has been giving me guidance. Thank you. Okay. Do I need to speak in this?
Can you hear him in the back?
Can you
okay?
guys hear me? Nah. Okay. All right. Is this better here?
Give it a try.
Hello? Can you hear me, guys? Yeah.
Up there we go.
Okay. Ooh. the guys in the front. All right, can you hear me now? 1, 2, 3, yep. Okay, better. All right, so I'm Michel Azer. I studied dentistry in Egypt. My graduation was 2011. And for the longest time in the US, I was known by Michel Azer. And then after 5 years, I decided to correct my name. So my name is Michel. I practice in Houston. And if you know a little bit about Texas, it's a heavy state on full arch restorations. Something that was very striking to me when I moved to Texas, I tried to look at associate positions, and then I found that there's no perio offices anymore. It's almost like everyone is doing full arch. So to me, that was a big challenge to come in and learn full arch, because that was not the thing I learned in residency. My perio residency was a typical flaps, grafting. So a lot of this came after learning full arch after graduation. So if you're on social media or recently, you're gonna see a surge of cases or people posting full arch cases. And there has been a recent interest now as we look at the social media or the implant companies, especially pushing for full arch restorations. So what is the reason why this is happening? I'm gonna first, to make this clear for you, why full arch is becoming more and more popular is mainly you're saving time and money for yourself and the patient, okay? To put this in better perspective, I'm gonna share with you my first case in residency where I got a full arch patient. I always like to start my presentations with a big failure. That's to break the ice between us because I still do mistakes. So that's my first patient who came in, completely edentulous. She's wearing dentures. And she said specifically to me, I don't want all on four. I told her, what's the reason why you don't want all on four? She told me that 4 implants are not enough for me. So I told her, okay, let's examine and see what would be the plan. So we came up with a very comprehensive plan. Our treatment plan for her was to do sinus augmentations, bone grafting, try to place 8 implants with guided surgery, and then after that, we're gonna be doing a delayed fashion. So she's gonna be in dentures after the whole healing phase. And then after that, give her what we hoped to be an FP1 restoration, okay? Now, looking at this here, there's no way to do an FP1 restoration. So with that in mind, our expected timeline for this patient after grafting and waiting for the necessary time is about 1.5 years. So we went ahead, our very first phase, this was the start of guided surgery as well. So we were so eager to do planning or pre-planning. That was also the phase where digital dentistry was coming into play with all the full arch and the implant restorations. So this was the first guide we made for a Nobel mini implant to be placed. Now, anyone here saw the Nobel mini implant or placed one other than Tom and the PSP group?
We never did that.
You never did it? Okay. There's a good reason why you're not doing it. So these mini implants are made of stainless steel, okay? And how they work, it's only one size, and then you measure how deep you want to place the implant, you cut it to where the desired length would be. And then after placement, that part on top here, you would bend it to make them all parallel. That implant is not meant to integrate. It's meant only for a temporary restoration. So we went ahead in a guided way, and then that's how we placed the first 4 implants. So when we placed these implants, we want to place them away from the area that we're grafting because we don't want it to occupy a future implant space. And then it's a typical conversion afterwards. So that's after the implants were placed on the same day. We did an anterior bone graft. That membrane is called the cytoplasm membrane. It's one of the trickiest membrane to work with because the rate of complication. However, as a Perio resident, you're just proving that you can do this procedure. And that's one of the big disconnect as a Perio resident to where I am now. I was too much focused on how much bone I can grow, and I didn't focus on the patient outcome, okay? So that's another reason why I'm showing you this case today. So after bone grafting, we focused, the sinus lifts and the bone grafts were not all done in one day. It was done on 3 sessions. And then we have to relieve the denture because any pressure at the suture line in that point will cause the suture line to open, and then you get an membrane exposure, and then you get failures with that or infections. This is how the healing went, which is an excellent healing here, okay? There's no opening of the membrane or incision line. And then while we're waiting for 9 months of healing, we started to do the try-in for the future denture or future restoration. So the pros residents started to do the try-in, an aesthetic try-in, to evaluate lip support, evaluate the aesthetic display. And then after that, the teeth there was a duplicate that made out of the try-in with a radio opaque material. So on the CT scan, you will see where your future teeth are going to go. Now, after 9 months of healing, that's the uncovery phase, and then it shows great bone, okay? One thing I'm learning by time now is not all the volume that you're getting from the bone graft is true bone or is good bone to be placing implants on. And one of the things that would control how much good that bone is would be how much autogenous bone you're placing into that bone. So after 9 months of healing, we did the uncovery, or we did expose the membrane, and then we aimed for a fully guided implant placement, as you can see here. And that was the final, or the time of implant placement. You would think that all implants should be completely inside bone. However, you can see this implant here outside, and then you can see a lot of this implant, for example, is just barely in bone or on the buccal. One thing that's very technical about fully guided surgeries is that you're not seeing where you're drilling. You're just following the guide blindly. Even though that guide was also secured by pins, when you're drilling into a bone that's part of it is soft because it's regenerated and part of it is hard because it's native bone, as you drill, your drill slides and then shifts to the buccal. And that's what happened with 2 of these implants here. So if you know, Perio residencies are only 3 years. So this case took about a year and a half by now, and I had to graduate. And I learned after my graduation that 4 implants fail out of 8. And then at that point, I started to ask myself questions, why is it failing? I mean, we grafted, we did everything by textbook, we waited enough time for the bone. And it doesn't seem to me as a full arch restoration, you do not need to get that grafting done. You need more to place the implants where the bone is, okay? And that's why the all-on-4 success rate is much higher than grafted cases, unless you have to graft for any other reason. So sadly, that patient ended up in the end with 4 implants that are not, in my opinion, enough to be holding a full arch restoration, because these implants are not the typical size of what we're going to do for an all-on-4. It's way smaller. So at 13 months, we had to speak to the patient that there's more surgeries or more grafting to be done. So that's why, in my opinion, bone grafting and sinus augmentation is very limited indication in full arch. And that's why all-on-4s are the success rate of all-on-4s is much higher for full arch restoration. Let's review here. One of these patients that came in, if you're talking about grafting, most of these patients are older, their healing capacity is altered. And then if you're gonna talk to a patient who's 80 years old about bone regeneration and sinus grafting, knowing that she wants the teeth today, that's a hard sell. That's sometimes a hard conversation to have with a patient that, okay, we're gonna do grafting and then a year and a half from now, we may be able to deliver the teeth. And then also keep in mind that their healing potential is altered and you're asking them not to wear dentures while the graft is healing. So a lot of these criteria or ideas or the patient perception is so important to address when you're doing a full arch restoration. So by moving on to the all-on-4 approach, it's documented by the Malo clinics. Its success rate is really high. After 18 months or 18 years of follow-up, the success rate on the maxilla is closer to 95%. On the mandible is a little bit higher than that. And so the idea of doing an all-on-4 restoration is that you're avoiding maintaining the gingiva. You're aiming at an FP3 restoration here. So FP1 is where you're avoiding any gum into your restoration. FP3, you're deliberately building the gum prosthetically. And then FP2, for us, it's a failed FP1, okay? Because you weren't able to maintain that papilla. So for an FP1 patient, the indications are pretty narrow, at least within the scope of my practice, because the way my practice runs, by the time the patient comes to see me, it's already in terminal dentition. Now, having said that, the biggest factor here for us as a dentist and also the patient is the cost difference and the time that it has to take to get you to the final teeth. Now, FP3s or full all-on-4 restoration, also they have their own limitations, and one of the limitations would be phonetics. The S sound especially is particularly harder to get over, especially if the implants are placed in a position that's more palatal. So sometimes patients would complain that the S's are so hard to get or getting used to. And that's a conversation I learned to have with all my patients in the consultation visit. If your job relies on you're a public speaker, you're a salesperson, I'm gonna have this conversation with you that the S's or speech can be a little bit altered because I don't want you to struggle for the rest of your life. And then at that point, we will discuss other options before we decide that all-on-4 or full arch restoration is gonna be good for you. So S's and SH sounds seems to be a challenge. And then that is one of the feedback I got on one of my patients who had this struggle with getting over the S sounds. That's from a speech therapist. And the tongue would slide against the palate or the dentoalveolar space of the palate to produce certain sounds like the S and SH, which we know now by doing an all-on-4 case, you're probably doing a lot of reduction, and that relationship between the palate and the teeth is compromised, and you're trying to rebuild that with the restoration. Now, the original all-on-4 technique was described as that you need bicortical stabilization, okay? So you need to engage the cortex at the crest, and you need to get the cortex at the bone that's surrounding your nasal cavity and sinus cavity, okay? Now, these bones, they have names. The bone at the piriform rim is called an endpoint. That term is described by Dr. Jensen, who's one of the leaders in full arch restorations. And then there's the Z point, which is recently published, and that's the bone up here closer to the inferior concha. And then there's the M point, V point is the nasal crest point. So why do we want to engage these points? Because it's much denser bone, and we know maxilla in general is soft. I just asked Tom before we start, do you normally engage that bone? And the answer is almost yes, unless the patient is particularly having such hard bone that you don't need to extend for bicortical stabilization. So that's one of an examples here for one of my patients. So I would start this here. That's a typical all-on-4 scenario. And then after we place these implants, we place multi-unit abutments to correct the angles to make them all parallel. Did everyone here use a multi-unit abutment or restore the full arch restoration? Yeah? Okay. So after we place these implants, because of the angulation, for those who didn't use a multi-unit abutment, to correct this angle, we need to place a multi-unit abutment that has specific angles or prefabricated angles, so you can get all these implants to be parallel in the end. Otherwise, your restoration is hard to see. So I'm going to walk you through one of my patients here. The lecture today is to show you what's the progression of digital dentistry until we get to the point of where we're practicing today with photogrammetry. So that's our patient. She came in for a consultation visit. She had these locator attachments placed for 20 years ago, and now she was looking for a full upper and lower reconstruction. So with a full mouth or full arch restoration, we're going to be doing the extraction of teeth. At the same day, we're placing the implants. And then after that, we're doing an immediate denture conversion, which most of us count on a technician to be present to do this conversion. So the expected timeline here is much better than my first case, is about 6 to 9 months. And the reason why there's a range, it all depends on how good we are at the record-taking process, starting the final impression process here. Because there is a lot of errors that can happen on the prosthetic level. So we start typical all-on-4 approach, take out the teeth, place the implants, put this multi-unit abutments here to make them as parallel as possible, and then put these cylinders in, and then you have a prefabricated denture that you would pick up by the acrylic, and then your technician is going to finish up this product over here. So a typical restoration would look like this here. Most of the times I'm placing more than 4 implants, but for the educational, I wanted to show you this here. That's a typical hybrid or immediate conversion. Now, my problem with that restoration here is that because you have to account for the size of the cylinder, you have to account for the acrylic, this surface area here is pretty thick, and it has to be built thick enough so that it won't break, because there's 2 layers that you have to accommodate. Now, because of that thickness, it makes the food trap much easier, and it makes the patient so used to bulkier teeth. The other problem, because you're kind of counting on immediate dentures to put that patient into the temporary restoration, the immediate dentures are typically not the most accurate dentures you're going to start with. So you're already starting from a point which is compromised. And then after the implants heal, you're looking at rehabilitating that patient from start again. So after waiting for enough time, how many did this step in their offices? Yeah? How did you like this step? It sucks. How many hours does it take you to finish 1 arch impression? How many patients complained of gagging? It's a dreadful appointment. When I first started my clinic, I didn't have any of the digital tools. So even though I had a technician helping me out to do this jig and lute the copings together, it took time to adapt the impression tray. And then after that, convincing the patient that this tray is going to be there for 4 minutes. And then after that, trying to loosen up all these screws here. That was a lot of stress. And then after that, you're probably getting, yeah, it's an accurate impression, but if the impression was not accurate, you're just like looking at this patient, okay, we're gonna do this again. And then it's so insane that patient has to be going through this again. So to me, that appointment, I used to book it on my calendar or my schedule for 4 hours for an upper and lower impressions, just in case I need to repeat. And that requires a lot of my time. Having said that, what happens here behind the scenes, because in my clinic also we do have a digital lab where we fabricate or take care of the production process. For you, or if you did that impression in your office, you send it out to the lab. The lab then takes this model and connects cam bodies. So these cam bodies are used for detecting the implant positions. And then the lab also would take another scan with the tissue scans. So like this here, so one impression with the scan bodies, another impression with the tissue scans. The scanner that's popular now is called Medit Desktop Scanner. And then there's another competitor that's coming now, it's called Shining 3D Autoscan. These scanners are meant to scan models. So keep in mind here that if your impression is not accurate to start with, then the scanner is just going to scan all the data as is. It doesn't matter how accurate that scanner would be. So this is how it works, the desktop scanner. You would place like a sticky or sticky material on that tray, and then you put the model one time without the scan bodies and one time with the scan bodies. And then the scanner would take a picture or capture a picture as is on the camera. So it's pretty accurate to do that impression. However, like I told you, there's polymerization shrinkage that would happen to the luted material, or sometimes the impression coping itself is not seated well. Or sometimes after they pour the model, the analogs would move inside the model because of the shrinkage. So you're introducing a lot of these errors here. And then after we fabricate or capture these details, we take it to a designing software. This designing software is called either Exocad or 3Shape. These are the two biggest players in our field. So this is the digital image that's taken after the model is scanned with the scan buddies. And then what happens on Exocad, this is a video, the lab or the designer would mark these scan bodies on the model and then put the digital analog on these models. So this is where the implants are in the digital world. Should have played that video faster. Okay, now I have the model digitized. Based on that, we're gonna first make a verification jig because we don't know if the impression is completely accurate or not. Verification jig can be made of printed material, 3D printed material, or it can be made of acrylic that the lab would fabricate. In addition to that, the lab would send me bite or wax try-ins or bite rims because we're not really happy with how the temps looked like, so we're now starting the process completely from scratch. The bite rims are made, so it's a bite rim that has screws in it, so you can just take the bite rim and screw it on top of the implant, so it's a little bit more accurate than what a denture bite rim would be. And then on that bite rim, sometimes it's way off. I'm gonna share with you my instructions to the lab. So one is to set up the teeth, the upper central incisors 2 millimeter more occlusal. You want to be as detailed as possible. And I send them these pictures, and then as well as a bite block to hold that vertical dimension. I should try to show them or explain to them where the teeth should go. This arch is kind of tilted. That patient wanted this arch to move outwards. So it's a lot of communication errors that can happen because there's always physical product that he's trying to understand based on your instructions. And then after that, the lab would fabricate a wax try-in. Now, this is a piece of art, right? There's a technician whose sole job is to put the teeth together to try to make it attractive for the patient. And then after that, we go in and place it in the patient's mouth. Now, if the patient doesn't like it, you should have a technician on hand who's able to do the wax or melt the wax and move the teeth to wherever we want to adjust the bite the right way. Now, God forbid, after taking this impression or taking this try-in, and then you notice that one of the implants that you place is coming from the buccal, and now you have to change an MUA or multi-unit abutment to bring it more lingually, then you have to retake the final impression again. And that's a hard conversation to have. Or you can just tell the patient, I'm going to accept a screw access hole that's coming from the buccal. I'm telling you this because it happened with me. Now, after you get all this information, that wax try-in goes to the lab, and then they do the scan of the wax after finalizing the teeth design. And based on that, if the final restoration is going to be acrylic, they do firing and then do an acrylic injection. If it's going to be in zirconia, then they have to design or follow what the try-in was and follow it with the design to make you a zirconia restoration. So this is how the design goes on the model. They design this bar here, and then after that, you do the secondary restoration. So this is the steps from the time the impression was taken, digital design, and then the bar. And then after the bars are milled, then you can mill that zirconia restoration here. It's a lot of work. How many of you knew about these steps happening in the lab? Yeah? Okay. Now, how many of you thinks that this is a nice result? I mean, it better be. That's, that's a lot of work. But the number of visits that it took us to finish this result here is probably closer to 10 visits. Each visit was about 2 hours long. Now, talking about patient who's already anxious to come to your office, and then coming into a try-in that they didn't like and spending that much time and pressure sometimes leads to an unhappy patient. So advantages of an all-on-4 for me is mainly time efficiency and cost efficiency. However, you're adding to your stress because all of this work that has to be done. Now, I'm gonna share with you the most updated way of doing all-on-4 restorations or all-on-X as we now know, which has no models at all. So the recent study that was published here that a lot of failures happen to the most posterior implant in case of a dual arch restoration, meaning an upper and lower all-on-X restoration. If you're placing 4 implants, that distal tilted implant will take a lot of pressure because the patient has no proper reception. They're just biting on food and then they can be eating to a very hard piece of meat, or sometimes they chew on bone. So sometimes they wouldn't know. And that's why my recommendation would be to place more than 4 implants. In my practice, I would be placing 6 implants on the maxilla and then 4 to 6 implants on the mandible. So I'm gonna walk you through a full case of how digital planning would go so that you're aware of what's happening nowadays. And then I know that this is the protocol that Tom and the PSP group are implementing now. So we start with the patient's smile and lip line record. We take a look at their panoramic X-ray to examine the sinuses, the nerve, exclude any pathology.
Michel, when you look at this patient, right, you just look at that panorax, and you look at the inferior border of the mandible, and you look at the angle of the mandible.
Yeah.
So one of the things that I've discouraged in our practice is doing dual arch therapy for a couple of reasons. One, I want to avoid what to me is the highest risk factor, which is that most of the time these patients exhibit significant parafunction.
Uh-huh.
And so I will typically advocate for patients to have a fixed lower arch done and have it opposing either natural dentition or a full upper denture first. And what I found is that if you wait, you'll get some atrophy of the masseter and temporalis complex, and then I feel more comfortable moving forward with the maxillary arch. And in that way, staging this therapy.
Yeah.
If you have a patient like that who's very clearly hypertrophic in terms of his elevators of the mandible, are you guys using Botox? What are the strategies you're using to try to get some atrophy of those muscles?
Yeah.
To protect against that function failure, what I call function failure.
Good. Did everyone understand the part that Tom was talking about? You can see the border of the mandible. There's a lot of muscle hypertrophy. So my strategy here is to place patient on Botox injections every 6 months. But I would test how is the temporary restoration doing first. If there's a lot of breakages in the temporary phase, then definitely it's a recommendation in the final. But if you go with your way, it's probably safest to do that. I tend to over-engineer my cases. So that's why 4 to 6 implants, majority get 6 implants as an extra layer of protection. All right, so we take pictures, we take the retracted pictures, and then we try to set up a digital smile design because as you can see here, there is a huge bite collapse into the jaw. And so this is how the preoperative scanning goes. And the plan for us was to open the bite from the mandible by 9 millimeters at the central incisor because your lower teeth is just hitting on the palate. So that's the preoperative scan. Let me come from here. Oops. So that's the preoperative scan here. And then we ask on the exocad software to open the vertical dimension by 9 millimeters. So you can see here, what we're showing here is the part of the central incisor before we start, and then that's the wax up of the future teeth. Okay? There's no models involved so far. So pre-op scan with the bite closed, that's the adjusted vertical dimension, and then that's the anatomic wax up based on the vertical dimension that we open. Now this is how the digital wax up would look like. And now I ask my lab technician to print an MUA guide, multi-unit abutment guide. So I'm able to get these multi-units exactly where the cingulum or the central fossa of these teeth. And then after that, we would ask for, from the digital wax up, because you can overlap that digital wax up to your CT scan, you would know how much bone to remove by knowing where this border would be. So this material here is a keystone resin, 3D printed resin, that we use both for multi-unit direction and also as a reduction guide so that there's no surprises after the restoration is done.
Michel,
Yes?
how did you determine the 9 millimeters to start?
The 9 millimeters to start is based on a visual wax up. We don't do a centric relation, but I'm going to tell you how we're going to overcome that in the next step.
You know, I know why he's asking the question though, because it looks like you were building a 9 millimeter central incisor, which seems
Correct.
kind of short.
Uh-huh. And that's exactly what happened.
Okay.
Yeah. Okay. All right. So you have your reduction markers in the back. You kind of know where the sinus is going to be flying. And then in the office, because I like to place 6 implants that are well distributed, there's a recent publication, and the authors here are all my friends, where we follow what we call a PADSI protocol. Okay, the PADSI protocol, we start with a most posterior implant first after the occlusal plane is reduced. And then we place the next implant in the anterior. And then in between, you're going to be placing either a tilted or a zygomatic implant. That way, you can get consistently 6 implants into the upper jaw. That's another configuration in case we have anterior atrophy, because now what we're seeing, people who had all-on-4s 20 years ago, they have some failures now or need some revisions, but there's not enough bone. So we have to utilize all the tricks we can utilize to get anterior implants done, besides doing a quad zygoma case. So one of the formulas would be posterior. These are pterygoid implants. Anyone heard of pterygoid implants? Yeah? Good. It's getting more popular now. It's a very safe implant too. And then we place the 2 anterior implants, and then we place the back 2 tilted ones or zygomatic if we need it in case of a sinus pneumatization. That would be the other variation here. In case of the tilted implants are not going to fit, then we're going to be placing 2 zygomatic implants. Now, we've all heard about zygomatic implants. There's a high complication rate. It used to be a high complication rate in the old days, because what previously was done, or the previous protocol was done, is you drill from the palate through and through into the zygomatic bone, and then you're kind of introducing bacteria into the sinus because there's a leak of bacteria. You're opening the sinus into the oral cavity. Back then, that was the only solution. Now, with the introduction of the new way of doing zygomatic implants, it's called extramaxillary approach, where you're basically working or brushing that implant outside the sinus membrane. So you're preserving the sinus intact throughout the whole process. And it also allows for the implant platform to be on the crestal bone instead of coming out from the palate. Okay? Now for the pterygoid implant, that's the piece of bone that we're trying to engage here. So you're engaging three pieces of bone. One is a little bit of tuberosity. Tuberosity is a very soft bone. The pyramidal process, and then the pterygoid bone, which is the last bone. That's a big implant. I'm gonna skip this part. Okay, so that's your typical pterygoid implant here. It starts about the second molar, third molar position, and then it's tilted to engage all these three complexes we spoke about: tuberosity, pyramidal bone, and then the pterygoid complex.
Michel, do you find you're able to have that procedure be guided? I have found when attempting those that it's a very blind procedure,
It is.
you know, and so you're just, I mean, this is more tactile than
Uh-huh.
almost anything else.
Yeah.
Are you able to find that you can do that procedure guided or not?
I have friends who do a pilot guide. Yeah, she was just drilled to the pilot and then remove the guide and then count on the osteotomes. The way I do it is osteotome technique, which I'm basically counting on hearing the bone as I tap into it. So with the pterygoid implant, I mean, there's a, I'll show you the video and I'll make you hear that sound that I'm talking about. So, okay, we start the procedure. This is the starting point. We place a palatal marker over here. And then on the right side, we do a retromolar marker. That marker is gonna be your fiducial marker after taking out the teeth, okay? That's a pterygoid implant here. So 2 anterior implants, 2 tilted implants, and then I want you to hear that sound. Did you hear that difference in sound? So as you tap through that pterygoid, let's repeat that again. As you drill into the pterygoid or the tuberosity, that sound is like a hollow sound. Okay? And then after you had that D1 bone, the pyramidal bone and the pterygoid bone, you're gonna feel like, okay? I want you to notice this here. See this? Right when you reach the first line, you're gonna hear that change in sound. Okay? So keep an ear on when this hits the bone.
19, 21, how long?
About 18. You don't want to be too long, then you're off. You don't want to be too short that you're purely in the tuberosity. Tuberosity is very like soft bone. That implant for sure is gonna fail after loading. Okay? So the first osteotome goes in all the way to depth. And then you can see here, I'm trying, if this osteotome was in tuberosity, you're gonna feel like oil coming out, the bone is moving. Over here, I'm just trying to move it and then it's stuck in. You almost have to twist and pull to take it out. And now, this is as we place the implant here, okay? So there's a specific carrier that attaches to the implant as we torque the implant in case it falls into the sinus, or worst would be the infratemporal space. That carrier is special for these pterygoid implants. So as you screw it in, you won't let go in case of the implant got loose, you can just take out the implant without any risk. So this is after all the placements were done. And now I'm connecting my first set of scan bodies, okay? This system is called a micron mapper. It's one of the photogrammetry systems that's available now. And we start that record-taking process. So micron mapper, see each of these scan bodies, it has a specific pattern on it that's detected by the photogrammetry camera. And then all what it does is it detects in 3D the position of these implants. So that's your final impression. That's the luted step here. Instead of taking 2 hours to take it, it basically takes 30 seconds to do it. And then since then, I'm hoping that my hair is going to turn black again. I think it's too late now. So as a periodontist, I always want to treat the tissue, so I'm removing the palatal tissue to make it thin, to make it more restorable. And then most of the times I'm taking tissue from the palate and then grafting the weaker areas. Sometimes the mandible would need some help because of lack of keratinized tissue. And now this is the final outcome. I have to admit that I placed an extra implant because I wasn't sure if this implant is gonna last or not. And that implant was just placed as a backup here. If this was successful, I'm just leaving this. I don't need to load it or uncover it. So to review the process again, we do take the initial wax up or the preoperative scan with one of the scan buddies or the TAD markers on the palate. Lower, this is our TAD marker. And then after taking out the teeth, we do another intraoral scan with the specific scan buddies. In this system is called the micromapper scan buddies. And then the third scan would be the photogrammetry one, the one that shows your implants in 3D. Now it's only a matter of the designer taking the common points and stitching them together. So the designer would take this point from the perioperative scan, stitch it to the intraoperative scan over here after the implants were placed, and then stitch these markers here to the photogrammetry. So you have all the 3 images all aligned together.
You know, Michelle, real quickly before you move on to the next step. So
Yeah.
interestingly enough, like Dr. Azer used palatal markers. But let's say you had kind of like a non-functional second molar that wasn't going to be part of your long-term plan. Yeah, there you go. Like down on bottom, that could be your fiducial marker. And photogrammetry is different from maybe your intraoral scanner that it's capturing these things at one time, so it can relate these things to one another in real time. It's not dependent on the pixel next to it, it's capturing them all together. The 3 dominant systems are ICAM, iPic, and MicronMapper.
Yeah, so ICAM, PIC, and MicroMapper.
So at PSV so far, we basically auditioned ICAM, iPic, and then MicronMapper will be the third one we're trying. Dr. Young, are you here?
I'm over here.
Okay, real quickly. So Dr. Young is helping us to audition those, and we'll be speaking at our Zoom meeting about that.
It's pretty cool. It saves a ton of time, and it's always accurate. I mean, what better can you get after this? So behind the scenes, that's what our designers would do. So they would I wish they work as fast as this, but not. So they align all that common markers all together, okay? So these are the scans. So palatal marker to palatal marker, and it merges.
Is there AI programs that can be developed for this stuff?
I think there will be. Very soon. But this requires heavily trained people to do it. It's not a dentist who can do this. This is a full-time designer. Best thing about this here is that your designer doesn't have to be in the office because it's all digital. You can send and forward files as needed. So this is the scan, the photogrammetry scan here, which is the more accurate scan to use. That's where you want to base your analogs. So bear in mind, so far, what we did is teeth extraction, placed the scan buddies, and took the scans. I didn't place any temporary copings. I didn't have any dentures so far. I'm going into the surgery without any dentures ready. Okay, so in this step, the designer is basically cleaning the impressions because there's bleeding, there's sutures, and trying to draw like a flat space or a flat ridge in where the restoration is going to sit on it.
Michelle, just for my knowledge, is this Ray doing this in the office? Or
No.
is this is the person you outsource the STL?
Exactly, yeah. And that's his name here. That's the name of the guy. That guy is based in Bulgaria. So we're coordinating the schedule really nicely where he doesn't sleep just to finish our work. We're getting to a flow now where we are doing the surgery and then the temporary delivery is delivered the next day. It just keeps everyone less stressed. The few complaints we've had is the patient, of course, is feeling the pressure the next day. We offer to numb. I use extraoral with the surgeries. Extraoral is a long-term anesthetic. It keeps patients numb for 5 days, and it helps a lot with that specific protocol. So now, that's the beautiful part about doing digital workflow, is that you can make this restoration way thinner than the typical conversion with the dentures. So over here, the designer not only is putting the teeth together, but also designing how the gums are gonna look like. And I always ask my designer to put a little bit of pressure on the gums so that we prepare the gum to have some sort of a groove inside so that there's less food traps at the tissue matures. Now I told him to record this video for education, so now he's being fancy and he's putting all canine eminences. Typically, I send out the files and I tell him, I need this ready in 30 seconds. Okay, so that's the file as after being calculated here. Now you'll notice that the design is gonna come out without having tie bases, without having anything. The latest technology in the screws that is holding that restoration to the implants is the major advancement, in my opinion. So that is the scans after aligning all of the workflow together. So now I can relate to where I place the implants to the preoperative scan. Now, if I did a good job to start with, that restoration would show excellent in the patient's mouth. Okay? So again, showing you here the superimposition of the analogs to the patient's preoperative scan. Okay? So that patient came to that position here after the second set of teeth delivery. Okay? I'm going to share with you a trick here. We moved from this patient where my instruction was to make a wax up for a 9mm central incisor. The second try-in, which is not here, came out really short where he's showing mostly lower teeth. And then after the second try-in, or the first try-in, or first set of teeth delivery, I take an upper and lower scans and then ask for more instructions. It's like starting the pre-op, but where the teeth are. So the designer would know, based on the pictures, where to position the teeth and where to position the lowers. Okay? But the nice thing about doing the try-in first, even if it was wrong, is you have way more references to indicate to the designer where to place the future teeth.
Just wondering, did he choose the shade or did you guys choose the shade? Or?
People in Texas like white. Chiclets white. I'm against that. I'm against that. I always advise them for not to. But you're gonna see all my cases like that. So please, please bear with me. Okay, so timeline. What we've able to accomplish in my clinic is that we're consistently getting these cases done in 5 months. So I need 3 months for the implants to heal, and I need, after 3 months, I start to work on the finals. About 2 months later, I'm delivering the finals, okay? Because first day, I'm taking the teeth out and delivering the first set of teeth. And then I'm bringing them in 1 week to deliver the corrected teeth. You know how the implant stability protocol or the primary stability to second stability, it takes about 3 weeks to drop. So at 1 week or 10 days, I'm still safe to change the teeth. And then I'm almost there as the finals. So once 3 months pass by, I'm happy. All what I do is collect a new gum record with the scanner, and then the patient already has the teeth that they wanted. So it's not restarting the process of finals after 3 months of healing. Make sense? Yes?
Let's talk about antibiotic coverage and giving these patients out of the switch.
My go-to for the antibiotics, my go-to is always amoxicillin or augmentin. If the patient is allergic to augmentin, I'm using now moxifloxacin. It's a Levaquin. It's the second best. I used to do clindamycin, and I saw a lot of problems with it. So now it's moxifloxacin.
500 milligrams.
Once a day. Yeah. Okay, so to me, that is the part where I want to be now. If my practice is going to be doing this, I do want not to worry about the final impression process because it's very stressful. Patients are gagging. I'm terrified of asking them for another impression. And in the first 10 days, I'm almost there with my final. I'm just keeping them in a temporary material until the gums heal, and then just the same file, I can transition it to the final restoration. So that's a comparison here. Doing the conventional way, you're paying for the temporary cylinders, you're paying for a denture to be made, the technician's time, and then after starting the final impression process, you're restarting the try-in process again. And that's why these cases can drag to 9 months. Versus what you're having here, that's a picture of the micron mapper, that's the photogrammetry camera and the scan bodies. You can make the try-ins in the office with 3D printing, and then once you get comfortable enough, then you can do in-house milling because it's pretty straightforward. You're not milling titanium for every case anymore. You're just printing or milling the zirconia that's going to go on top of the teeth.
And then, Michel, is it correct that in many of these cases, there is no longer a tie-based zirconia
Correct.
interface, right? It's just the tie-base.
It's zirconia to MUA.
Yes, right to the multi-unit level.
Yeah. Okay, let's put a twist in this. So this is one of my patients here. So she was seen by the school, the local school, but she told me it's taking too long. I've been in treatment for almost 4 years, and I'm in dentures for 4 years. So I told her, why is it taking that long? So one visit was for taking the teeth out, let it heal, and then doing the upper and lower dentures, let this adapt, and then bone grafting, 9 months, and then implant placement, another 5 months. So it's dragging for too long. So that's how she presented to our office with dentures. This is the smile before the dentures. And then so we just do whatever protocol I just described to you. The sutures were still present from the last surgery she had, which was the implant placement. So that's the palatal marker, like I showed you earlier. And then that's the midline marker on the mandible. If you ask me why I'm placing this here, it's probably because I'm lazy to go into the retromolar area. Okay, so it's just easier for me to do it here. I just place it low enough, so by the time I'm doing occlusal reduction, it's not interfering with my implant placement. Now, because she had dentures, excellent dentures in place, I just captured that preoperative scan, and I made a hole into the denture, showing where my scan body or TAD marker is. And then that's how the scan looks like here. Now on the mandible, I just modify the denture here and then do this scan. So I plan to remove all these implants. And then, like I told you, start with the most posterior, pterygoids, and then anterior, and then the tilted implants. At this point, I'm going to start taking the records here. So photogrammetry scan body is taken. We take the photogrammetry image, which is almost every time is 100% accuracy. And it only takes about 30 seconds to do it. And then this is the final position of the implants in 3D. Now I take these scans here, and then on exocad, this will be the analogs, or this is what they're going to determine the analogs. And then I suture up, and then take another scan here with the micromapper scan bodies with the palatal marker. What I modified a little bit on this protocol is we designed these scan bodies. These are in-house made scan bodies. And the idea for us is after the soft tissue heals in 3 months, I'm just going to be connecting these scan bodies here, which is made in our lab, and then just take a regular tissue scan. And then I can adapt that new tissue scans after 3 months, because the gums is going to shrink after 3 months, and then just adapt all the previous scans to it. So this is becoming now, you saw this before. And this is how all the records are all aligned together. So the analogs of where the implants were placed based to the preoperative scan, which is the denture that she had from before. Is this all making sense? Yeah? Okay, now what I'm showing you here is the wax up based on the dentures. So if the dentures were not showing enough, we're asking the lab to show a little bit more teeth. And then now you got your final restoration here. Okay, yes?
You mentioned that this was more cost effective for the patient. Do I understand you say that? Than traditional fees?
It's more cost effective for us. And now from a feasibility point, I can pass that to the patient. Correct. Because it's less time chairside, you're hiring less technicians, and you're probably getting the right set of teeth or design early on. You don't need to restart the process after 3 months. So it's a lot of savings that you can do. Me and Tom are speaking about how can we complement this workflow for a referral-based office, right? There is a lot of room where there is collaboration can happen, because all the records can be transferred, and then it's easy to transfer that record to a lab that you like, or even produce it, and then it becomes less of a hassle to finish the product.
Just real quickly as a survey, who's doing some kind of intraoral scanning right now? For aligners or for individual units, right? Everyone's doing this to some degree. This is not the future. This is actually like definitely right now. So where photogrammetry to me really, it kind of bridges this interesting space where, so let's say that like Dr. Mark Norley and I, or Dr. David, you and I, we've done a number of these cases together, Dr. Rodi and I would go to their office with my Cois articulator and a Cois spatial analyzer and my mounting plate and my mounting stone, and I would go there and I would take and index the maxillary arch provisional. We would have a verified implant model already, like we've already done Dr. Azer's dreaded implant verification jig point. We would take the provisional off, we would mount it to the model, using the Cois spatial analyzer and mounting plate, we would mount the maxillary model, and we would take the mandibular model, we would mount this. And we were actually doing this in the office so we could protect against lab error. We're gonna do this knowing that the wax up's gonna come back off by a little bit, but then we'll be able to take a new bite, and then that's how we'll get to the PMMA. provisional, and that's how we'll get to the final restoration. And that means that I'm blocking off chair time to go to the office to do these various steps, because I want to be able to do the surgery, and I don't want Dave, Tom, Brett, or Mark to say, I don't want to deal with this, right? This is absolutely integrating all those processes in real time. This is making it much more efficient. And that brings price point down, that makes access to this care greater. And why is that really important? Well, this is kind of fogging the line between where the surgery stops and the restorative process actually kind of begins too, right? And so if you're not going to do this surgery yourself, you need to work with a surgical practice that wants to integrate some of these processes so the handoff is at a clean point, and that point of handoff can be at the 300 meter mark, the 400 meter mark, the 500, wherever in the process you want to be able to pick it up. And so that's what Dr. Young and I were talking about.
Yeah. Okay. Now we start to do the lower restoration. So this is pretty much a typical all-on-4. Remember that we placed that tap marker more apical than our occlusal reduction. At this point, it becomes boring. You already know it. So scan of the scan bodies, photogrammetry scan. And now this is the produced design. So if you see here, that is the milled PMMA. So if my first set is delivered in one day, or same day or next day, and I'm happy with it, then I'm forwarding that design to a milled PMMA. Milled PMMA is a little bit stronger than 3D printed resin. I know you're gonna have this outside where they tell you printed resin is good. It's really good until you meet someone who's Broxer, and then you're gonna dread doing it. So think about this as an option as well. And we've had less breakages with that PMMA model. Now, here's the fun part. What used to be the final impression and luted copings, which is the dreadful appointment, now it's becoming an internal or an intraoral tissue scan. So this is how the tissues would heal. Because we applied pressure at the right points with our digital design, this is how the X-ray looks like after the 3 months of healing. And now this is how the CT scan would be confirmed. Remember, we spoke about the M points, the Z points, and the V point. So this is where the implant is engaging here. This is the M point, which is very hard cortical bone. And now this is how she looks like only in the temporary material. Okay, this is not her finals. So again, treatment time, consistently 5 months. Another case. This is the part where I'm gonna show you what happens when you don't get it right, okay? Preoperative evaluation, severely pneumatized sinus. That tooth is, I don't know what we can do, why he's keeping it, why this tooth is remaining. So this is the preoperative scans. And we start the surgery, palatal marker, midline marker. Start with the posteriors, pterygoids. At his stage here, because of how the sinuses were pneumatized, this is the extramaxillary approach. This is how we access the zygomatic bone from outside the sinus. And then you elevate the sinus. It's a pretty delicate procedure. It's not anymore about how far or how good you are with the drilling. You have to preserve how the sinus is lifted. And then there's a specific burr, which is an extremely long diamond burr. You create a channel outside the sinus, and then you start your drilling. So if you notice here how the drill goes, nothing is interfering with the sinus. Okay? And I also want to give you this model to pass it around, just to give you an idea of what the implants look like with that new zygomatic implant approach. With the zygomatic implants, you typically want to place these implants a little bit towards the inferior border of the zygoma. The higher you go up, the less room you have into your zygomatic bone, let's say in case of a revision. So you always want to place your zygomatic implant lower into that bone to preserve zone A and B. Let's say if that implant failed or you need another implant for the anterior, then you can utilize this bone. Okay, so this is after the placement of the 6 implants here. As a periodontist, and I'm not being biased, but we do really understand how soft tissue works. When you're placing these implants, if you're a little bit more superficial, that can lead to dehiscence. So you do want to place these implants a little bit inside the bony housing so you don't get dehiscence of soft tissue afterwards. Even though if that happened, most modern zygomatic implants are made of a shiny or a polished metal, so that soft tissue won't get a lot of bacterial traction. Now we go ahead, same protocol, photogrammetry, collect the 3D position, preoperative scans with a TAD marker. And then on the lower, same exact protocol. Place implants, collect the scan bodies. You only need 3 scans per arch.
Michel, would you go back 2 slides? So this is the passive protocol. Posteriors first, those are your pterygoid placements.
Yeah.
Then you have the anteriors, and then you have your angled implants. In this case, you have 2 zygomatic.
Correct.
implants.
Yeah.
Dr. Zahedi and I were both with Mike Bikos, as you know, down in Florida, and we had done the training on this implant. One of the things they talked about was the typical dental implant, the average length will be between 10 and 13 millimeters. Those are 55 millimeters in many cases.
Yeah.
And these implants are still made of titanium, and they'll flex a little bit. Like at that point, they're the middle implants. If you press on them, would you notice a little bit of movement?
So as you, with the whole restoration?
No, I'm talking about just them individually. I'm wondering how much structural benefit they provide to the overall restoration, because even though they're rigidly fixated at their apex, right here at the implant,
there is a lot of
interface,
movement.
There's still a little bit of movement.
Yeah. So it's very well documented that the zygomatic implants are gonna flex because it's a huge cantilever, right? So you always want to have an anterior and posterior support. That's why quad zygomas, if you don't place an anterior implant, even if it was a nasopalatine implant, these implants are gonna keep moving, and then you get, first of all, loosening of the screws or breakages. So again, that's the benefit of, if you're gonna do quad zygomas, to add posterior stop and anterior stop, so it won't keep flexing. We try to stay away from just doing quads and stopping there. Okay. So again, this is becoming boring now. Same technique, stitch, stitch. This is how the post-operative view. And now this is the first set of teeth we delivered here. Notice that there's no tie bases. This is how it's all printed in one shot. Now this is how the patient came in. That's exactly what you talked to us about, that the lowers were showing way more. And I think that can be a problem with the preoperative design that comes from mainly the doctor who's placing it. So if that happens here, we take a scan of these teeth after they're placed, and then we forward that to the designer with the tooth itself, with the pictures itself, showing where the midline needs to be and then how much of less view we want to show from the lower teeth. And so the designer then would go in, plug in that new scan or that new bite, and then start to do a wax up of the future teeth where this is all corrected. Very simple. Okay, so you can compare now how much we move the teeth down, and also we move the midline to the side. Yes?
Can they overlay the facial with the soft tissue?
Yes. So his question is, can we overlap the patient's pictures with the bite? And then you can definitely do that, or even better, a 3-dimensional or a facial scanner. We don't do facial scanning. We relay all the information by pictures. Okay, and then this is the new wax up here. After that minor modification, again, I'm trying to explain to you that you have a room that in 1 week or 10 days, you can be delivering this restoration because your implant stability didn't dip too much. And that's basically it. That's how you get the cases done. 3 months later, because of proper soft tissue management, all that surface of the zygoma here is not going to be evident. It looks just like a normal implant would be. Now, this is the fun part. You just take the scan bodies, do an intraoral scan again to update where the tissue is, and the teeth setup is all correct. All what you need to do is adapt the intaglio part against the new gum level. And then this is how it looks like in the final restoration. That's the lower. And then that's how the teeth look like here. No tie bases. Everything goes straight from the zirconia to the MUA. Yes?
So with the provisionals, so once the surgery is done, healing is done, you get the provisionals on, do they go straight into zirconia or do you put them through some sort of acrylic?
So the provisional can be made of 3D printed resin, or it can be made of a milled PMMA. What I like to do is place them on a 3 months in provisionals, and then after that, take the tissue scan and then deliver the zirconia. If there's any minor adjustments to the shape of the teeth for cosmetic purposes, you can also apply that. We do one more try-in before the zirconia where I'm trying to fit how the teeth are going to look like against the gums so that there's not much pressure or gaps before we mill the zirconia. Okay? And then this is how the final design looks like. Okay. One last case. Any questions so far? Is this making more sense now? Yes.
Do you ever have to find abutment loosening between initial placement and the second?
Yes. Anytime I have an abutment loosening, I would retake the photogrammetry again. That happened? Yeah, it can happen. I think it's a good indication that things were not perfectly right. Sometimes there is bone in the way of the multi-unit abutment. So after the bone resorbs, it gets loose.
No, actually, I have a question about that. So full disclosure, Stephanie and Michelle, the initial cases that I did, I was still placing Nobel trialers. And I have a special place in my heart for Nobel replace because I feel like the geometry of the implant works very well for media placement, which is why I stayed with that body through conical connection. But because there were only 3 seating positions for multi-unit abutments, I think maybe a half a dozen of my first cases, we used non-engaging 30-degree posterior multi-unit abutments. If one of those were to loosen, I don't lose sleep about very much, but occasionally I do think about that. If one of those were to loosen, and I'll ask you after to give me the answer, how to reorient that, retighten it to maintain the same geometry. Tell me after, okay? Oh, you're telling me there's no way, okay. That's what I was worried about.
I think that's what she is.
Feeling on kosher.
Yeah.
And these were angled MUAs, not straight?
Of course, 30 degree.
Oh, wow. Yeah.
Sorry, Dr. Kim. Sorry, Dr. Ruby.
All right. So one last patient here. So this patient, I showed you her pictures before we start, okay? Before we start talking about full digital workflows. 80-year-old diabetes. That's not the patient that you're going to be doing any grafting on. This is how her x-rays look like. Even though I was so excited to see that there is bone on the panoramic x-ray, on the CT scan, it just looked too bad here. There's no bone whatsoever. Even the remaining bone, it looks like bone graft from the previous extractions. So I wouldn't feel comfortable placing implants here. So plan A, based on the panel, you can do an all-on-4, but that's where surprises can happen. Plan B is to do zygomatic implants. We spoke about this. We always want to place the zygomatic implants lower border of the zygoma. So that's how her bone looks like, extremely thin bone all over here. This is how the bone looks like. So I always want to expose a little bit of the nasal cavity because it helps me to aim where the implant is going to go to engage that cortical bone. Starting with pterygoid implants, both sides. Zygomatic implant, make a small window, expose the sinus, elevate the sinus gently, and then use that diamond burr to create a channel where the future implant is going to sit. Now, first implant is done here. And now this is how the patient looks like. This is exactly, Tom, where I wanted to add an anterior stop to prevent that flex. Now, this is buccal fat pad because I wasn't really sure if there's going to be soft tissue dehiscence. So I advanced the buccal fat to cover all that shiny surface of the implant. And now this is after full suturing here. That case, I started it before I get photogrammetry into the office. So that's how the implants were placed. That's the temporary. And then 3 months afterwards, at that point, I had that system. So I started to retake the records again. I mean, you can do that step at any time of the treatment. And then this is how the restoration looks like on design here outside the mouth, and then this is inside the mouth. Now this is how she looks like exactly 5 months after this treatment. Okay? Pretty easy. Yes?
Not this case, but some of the previous cases I
Yeah.
noticed, even on the mandible, the angle from the posterior implant. Why is that?
I always angle the most posterior ones to get back support to the most posterior tooth. The alternative would be placing shorter implants that are straight in the first molar position. Sometimes the bone doesn't allow, and sometimes the nerve is too shallow. So I always angle the premolar ones or premolar molar beyond to where I avoid the mental nerve, two front ones. And then if needed for bruxism, if I have the capacity to do it, then I'm adding number 5 and 6 in the first molar position. Okay? Yes?
Sure. Thank you so much. As always, great presentation. So actually, I have 2 questions. I'm starting with the second one. So let's say you plan the patient for placing 6 implants, no zygomatic implants. If it happened during surgery, you didn't get enough primary stability, let's say for the trigonometry or something, so you have to place 2 zygomatic implants. What's your protocol to explain for the patient before the surgery? I'm going to place 2 long implants that go into your cheeks or
Okay.
your sinus. Do you explain this one, get a special consent or?
So that's a good question. So what's my thought process? I mean, the patient is probably sedated by that point, right? It's too late to talk about anything. So So all of this conversation will happen before the procedure. So I'm going to tell them that we're planning to do this procedure for you for the implant placement. If in case I don't have enough bone stability to the implants, or there's enough bone because of infection, then I have to place these advanced implants. And that would be the additional cost to it. But I don't make them pay for it upfront.
Charge extra for the like.
Yes. It takes a little bit longer to place zygomatic implants. It requires extra training, so it should be charged extra.
But Perio should be the same as that.
Depends how nice the patient is. Let's put it this way. Yes.
First question. So one of the primary principles of the implant placement, let's say conventional by Dr. Nish, is that we place the implant prosthetically, not bone, right?
Uh-huh.
So, but in all of our cases, in all of our treatment plan, it looks like we just place the implant based on the available bones in any direction. But because finally we are going to use the rectangular development to correct the angle and finally spring the implants. So it's going to compensate all of those negative factors that make bones. So is it correct that you're placing implants bone driven, not the prosthetic?
I think so. One of my experiences, if you get too stuck into that prosthetically driven approach, it may lead to excessive bone augmentation procedures, and sometimes that's not desired. And even after you do the bone grafting, it doesn't necessarily mean the best regeneration quality of bone. So you can be waiting for that long. I mean, I showed you the very first case where I waited 9 months, and then after placement, still the implants failed because it wasn't fully vascularized or healthy bone. It was just like a scaffold of bone. So I do trust more native bone always to place our implants. Now, we don't want to compromise the thickness of the restoration. Let's say for a single tooth, for example, I like to place immediate implants, but if it's too much compromise where the implant is going to come out too far lingually or facially, then it's better to stage it. But full arch is a different game.
So you don't have any concern when you place implant about the angulation?
Never.
Because finally you're going to splint it.
Exactly, yeah. But I would, yeah.
I was just gonna say, I think that the other thing that matters a lot is the place where implant placement errors are least forgiving are at the incisal edge and relative to the actual insertion point to the bone. The more apically you go, and by definition, these FP3 prostheses, you're looking at between 14 and 16 millimeters of reduction anyway. You can correct for the tooth position relative to the implant position with the greater the delta is between that, right? So if you only have 9 millimeters between the implant abutment interface and the tooth, that's a greater challenge to correct. The higher your implant is placed relative to the tooth plane of occlusion,
Yeah.
the more room you have to correct it.
That's true. Yeah. Okay. Any other questions? Good. All right. So thank you, guys. I want to thank you. Look who's here. So Claire was one of the people who actually helped me a lot with my practice. I used to have a lot of sleepless nights because of the final impressions, but Claire came to fix that. So feel free to communicate with me or text me if you have any questions about these cases, or you feel like the lab you're working with is struggling with a specific point. I mean, we do work with other labs to teach them a little bit on how to implement that system. And enjoy your evening. I hope you're not too drunk by now.
Okay, well, thank you all for coming. Next month's presentation, I'll be presenting it. It'll be on a toothbrush that we're starting to work with right now. Your dental hygienists are invited to that meeting. We hope that you'll all be able to come. Otherwise, another round of applause for our graduates. Thanks, Michelle.
Thank you, guys.
Make sure you fill out your
Yeah. Okay, I don't know how to. Oh, good, so I'm just, my daughter was